Today, we will go through our International Patient Safety Goals, also known as IPSG. We will go through the purpose, the 6 goals, and we will end with a quiz. So the purpose of IPSG. IPSG is to highlight the problematic areas in healthcare. It also describes evidence-based and expert-based consensus solution. Therefore, it is very important for everyone to incorporate it into our daily practice. This is from JCI standards regarding International Patient Safety Goals, a summary of all 6 goals. JCI stands for Joint Commission International. So we can tell that it involves the holistic care of patients for all these 6 goals. Goal 1, identify patients correctly. Goal 2, improve effective communication. Goal 3, improve the safety of high alert medications. Goal 4, ensure correct site, correct procedure, correct patient surgery. Goal 5, reduce the risk of healthcare associated infections. Goal 6, reduce the risk of patient harm resulting from falls. So, Goal 1, identify patients correctly. So how can we identify patients correctly? By using 2 unique identifiers. So what are the 2 unique identifiers? We can divide it to inpatient and outpatient. For inpatient, we can ask the patient's full name and medical record number. For outpatient, we can cross-check with the date of birth of the patient and also the IC. However, in the event of the patient is unable to verbalize the name or MRN, we can refer to the next of kin. So when we ask the patient, "Encik nama siapa?" the person will reply, "Nama saya Ali bin Abu Bakar." So that is the full name. Following, we cross-check with the wristband. Patient's wristband, identity band, which will have the patient's MRN. After that, we will ask the patient to tell the name of birth, date of birth. Therefore, we have 2 unique identifiers. We should never use patient's room number as an identifier because their room number can change. Same goes to their location. And using the race as an identifier, it is too general and should never be used also. Before administrating these procedures or treatments, we need to identify patients correctly. This list is just an example, but there are many other procedures and treatments that we need to identify patients before. So examples, administrating medication or blood products, serving a restricted diet tray, providing radiation therapy, taking blood specimens, interward transfer, performing any procedures such as cardiac catheterization. So here are the steps written down on how to identify the right patient. Step 1. Ask patient to read out his or her name. Cross-check this with his name tag. Subsequently, check the MRN of the patient on the identity tag together with your relevant documents. From there, you can match the following: patient's ID with the medical records, or the procedure list, or the drug prescription, and so on, such as lab or blood request form and radiology reports. All blood samples must be labeled beside the patient. This is an example of an identity wristband. An identity wristband is a standardized identifier throughout the world. There needs to be the name of the patient's date of birth, the MRN registered to the hospital, patient's gender, and patient's age. So, if the wristband is lost, defective, dirty, or the details have been faded away, it must be replaced immediately. And all patients in our ward should wear the band until discharge. Where should we attach patient's identifier, in this case the wristband, other than the wrist? So there are some situations where we cannot use the wrist or the lower limb to attach the patient's wristband. So what we can do is we can do at the deltoid area, the upper arm, or Or if you have difficulties applying the ID band, you need to inform your supervisor and the doctors to identify and come to a decision for where to locate or where to place this and whether documentation should be made. So if there's really no other place where you can put the patient's wrist tag, you can put it on the patient's clothes. Again, it needs to be clipped, securely fastened, and relevant documentation should have been done and agreed with your nursing supervisor and the doctor in charge. Here are a few special situations where we need to identify patients using wristbands in a way where they do not have a name yet. So example, an unconscious patient in ED who we do not know the name. So what happens is we will name this patient as unknown 1. If it happens to have another patient, we'll name that patient unknown 2. Another situation is when a newborn is given 2 tags. First, issued at the labor room, and second, at the nursery. These are attached at baby's hands and leg. The baby's tags cannot be removed while in the hospital. They are required to be removed by the parent only at home. This one repeat, only at home it can be removed. Now we are going for goal 2, improve effective communication. So what does it mean by improve effective communication? Such example is when handover of patient care, either intra-hospital or inter-hospital. We should standardize critical content communication during handovers. Such example, we use the IDRT, or commonly we use the S-bar tool. S-bar tool is usually used in emergency or urgent clinical situations, but it can also be expanded if you are more familiar with S-bar. S stands for situation, B for background, A for assessment, R for recommendations. Aside from that, we can talk about improved effective communication verbally or via phone, especially when communicating critical results. So, if you are informed with critical results, write it down. Don't just listen it over the phone. Write it down, read it back to the receiver, and reconfirm it. The caller needs to reconfirm it. Alright, so here are the turnaround time to receive critical care results. If it's inpatient, it needs to be informed within 1 hour. Outpatient needs to be informed and acknowledged in 2 hours. So here is one of the tools that we use, which is ISBA. I, introduction. You introduce who you are, what role you play, and why are you calling. S, situation, what is happening at the moment. It can be either a situation related to patient, or it can be either an operations, a pharmacy, or a financial situation. Background, what leads up to this situation. Assessment, it is what you believe the problem is, and recommendation is what your suggestion to be done to correct this situation. A lot of times we miss out this recommendation part. We only provide situation, background, and assessment, but we fail to provide the recommendation. It is okay to give recommendation. It helps to improve the learning process. Verbal medication orders are reserved for emergency situations or when the doctor is not present in the hospital. So when you receive a medication order from a physician through the telephone, you need to write it down. After writing it down, you read back the order to the physician or to the doctor. Then subsequently, the doctor will confirm and verify your order is correct. And then the nurse will check with another nurse and make sure to document the date and time the order was received and stamp your name and your title. So these are the following details that needs to be written in a medication chart when the verbal order is received. The drug name, the dosage or the drip regime, the frequency, the quantity or duration, the route of administration, and the time and date. Readback policy is not applicable in situations where the verbal order that is received cannot be repeated, such as in code blue. This is when time is precious. We also need to focus on improved communication via the handover of patient care. This is commonly done between and during shift changes. Either that or we transfer patient from general ward to critical care ward or vice versa. Sometimes we also do it when we send patient to diagnostic units. I mean, we should always do it when we send patient to diagnostic units or send the patient to clinic areas for certain procedures to be done there. So during the handover, we need to refer any abnormal values in change of patient's condition to the physician. This is very important to prevent breakdown in communication. When there's breakdown in communication or loss of information, there will be adverse events or errors. It is important that we also establish good handover or improved communication process when receiving or reporting critical results of diagnostic tests. So in this situation, the reporter or the lab technician will provide the report to the receiver. The receiver will then document the critical results and will read back the information provided, including the patient's name and MRN to the reporter. Then, the lab technician will verify the information to be correct. Both the reporter and the receiver must document the readback procedure, which was carried out, inclusive of the date and time when the report was communicated, in- alongside with the name of both reporter and receiver. Moving on, we talk about goal 3, improve the safety of high alert medications. So, what are high alert medications? In short, HAM. These are medications that pose an increased risk to cause harm to patients if it is used in error. There is an independent double checks that is in place when handling these medications. All of these high alert medications are labeled with a high alert sticker, and this sticker is on the container where the drugs are stored. And also, the sticker needs to be placed on dispensed drugs from pharmacy and when patients bring their own medications from home. So here are some high alert medications I wish to highlight. First is concentrated potassium, okay, potassium chloride, concentrated phosphate, potassium phosphate, concentrated calcium, which is calcium gluconate or calcium chloride, and lastly, concentrated magnesium in the form of magnesium sulfate. Aside from that, we also have hypertonic saline. This is found in an IV drip bottle, which is 3% saline instead of the regular 0.9 saline. This list here, or this poster here, are the list of drugs and its color sticker that is found in our hospital. You may find this as beside the high alert medication cabinet. So the usage of all these high alert medications are limited. All prescriptions must be having the indicated dosage, frequency, quantity, route of administration, and orders need to be signed by a doctor, either the consultant or medical officer. The pharmacy staff will pack and dispense the medication via a thorough tracking system. Written prescriptions will be issued as one-day supply, whereas medication prescribed via verbal order can only be supplied for one dose, and the prescription needs to be signed again within 24 hours. For all these medication, as I mentioned, there must be the high alert sticker. And if you were to give high concentration electrolytes, you must use an infusion pump. True registeredness are required before administration, and this process has to be recorded. If the cover of the vial is open before the medication has been used, then the medication needs to be disposed immediately. The balance of the medication that is not in use must be returned to the pharmacy shortly after the treatment is completed. This must happen not more than 24 hours. Unopened medications need to be kept in emergency trolley, and certain units such as the emergency department, ICU, OT are allowed to store it in a locked cabinet. So here is an example of where concentrated electrolytes can be found. This list is not conclusive and may change from time to time, but it's just an overview of areas such as the OT and ICU are allowed to cap concentrated electrolytes such as calcium chloride and calcium gluconate, along with potassium chloride. Look-alike, sum-alike drugs is next on the list for medication safety. So this is also known as LASA. LASA medications are not included in the high alert medication list. To differentiate LASA medications, we use tall-man lettering labels. LASA medications without tall-man lettering approval will be named and labeled as name alert. So this list here is an example of 16 look-alike, sum-alike medication. Commonly, we can say number 7, Diplan and Deflon sounds the same. Number 6, amlodipine, felodipine sounds almost the same. Alright, I give you your own time to look at this medication. You may pause the video to look at it. So this is what I mean by tall man lettering. The tall man means we capitalize the letters in a medication name that differentiates it from its look-alike, sum-alike counterpart. For example, we can look at 16 and 17, dufaston and duphastalin. The aston in dufaston is tall man, or in other words, caps lock, and then for the talin in duphastalin is caps lock. That way, we can attract our attention, bring to our attention the difference in its spelling. For goal 4, which is ensure correct site, correct procedure, and correct patient during surgery. All procedures, either in the OR, the cath lab, the endoscopy unit, or the X-ray department, must follow this. And this is carried out by all healthcare staff, surgeon, anesthesiologists, other doctors, MO and nurse needs to ensure this policy is effectively enforced. Before carrying on the procedure on a patient, the circulating nurse is responsible for initiating a time-out process, which requires to get the attention of the entire operating team. In this Goal 4, we also talk about correct site of surgery. So it is a universal protocol that we mark the surgical site with a skin marker. Aside from that, there's a pre-operative verification process on the correct site. And during the time out, there needs to be another verification and mentioning of the site before starting the procedure. So this is to state it out where these precautions need to be taken place. The OR, the invasive cardiac lab, the endoscopy unit, the interventional radiology unit, the daycare unit, and any other bedside procedures. So let's talk about pre-operative verification process. This process occurs when the patient is still conscious and must be documented in the pre-operative verification records. The verification process is carried out at the OR receiving bay or the patient's bedside by the OR or wards nurse, and before induction by the anesthesiologist and the GA nurse. So when we mark the area of surgery, we need to use a permanent skin marker and this must take place when the patient is awake and aware, whenever possible. It needs to be done in all cases involving laterality, means right or left, or multiple structures such as fingers, toes, or some lesions. The same goes if there is multiple levels or regions such as the spine. This marking has to be documented in the medical records and needs to be confirmed every transfer and final verification before surgery. So we're now talking about time out. Time out needs to be formed right before the start of the procedure of surgery, and it is done in the presence of all members of the surgical team and the patients. No one from the team should leave the room, and everybody should remain silent except for the timeout leader. So the timeout leader needs to mention the correct patient, the correct procedure, treatment or surgery verified with the consent, correct site or site, correct imaging report or medical records if available, review if there's any anticoagulant used for the patient, and correct equipment required for the surgery. Subsequently, we need to document the timeout, which includes the date and time when the timeout was carried out, along with the name and signature of the staff that started or was leading the timeout, and names of all team members involved in the timeout. Moving on to goal 5, which is to reduce the risk of healthcare associated infections. So what does it mean by reduce the risk of healthcare associated infections? Infection prevention and control are challenging in most healthcare settings, and the rising rates of healthcare associated infections are a major concern for patients and healthcare practitioners. This is common in many healthcare settings, such including catheter-associated urinary tract infection, bloodstream infections, and healthcare-associated pneumonia, which is often noted in patients having mechanical ventilations. To eliminate all of these and other infections, the key is proper hand hygiene. All healthcare workers must adhere to the hand hygiene 5 moments. We can achieve this by using alcohol-based hand rub or washing hands with an antiseptic agent. To ensure compliance, hand hygiene audits are regularly conducted, and we have also placed reminders at relevant locations to promote the practice of hand hygiene. This is the 5 moments of hand hygiene. First moment, before patient contact. Second, before aseptic task. Third, after body fluid exposure risk. Fourth, after patient contact. And lastly, after contact with patient surroundings. So, to further elaborate, before patient contact, when clean your hands before touching the patient. Why? We protect the patient from germs on our hands. Next, before an aseptic task, we clean our hands immediately before any aseptic task, is to protect the patients as we are doing any procedures. Third, after body fluid exposure risk, we clean our hands immediately after having an exposure risk. And this is definitely done after you have removed your gloves. This is to protect yourself and the environment from harmful germs from the patient. After patient contact, clean your hands after touching the patient or the immediate surroundings is to also protect yourself and the environment. And lastly, we clean after contact with patient surroundings. This means clean after touching any object such as furniture, curtains, patient's cup, patient's tray. Even if you didn't touch the patient, you need to clean it when you leave the surroundings. Again, this is to protect yourself and the environment from harmful patient germs. Now we talk about the goal 6, which is reduce the risk of patient harm resulting from falls. Falls account for a significant portion of injuries in hospitalized patients. Every organization should evaluate its patients' risk of falls and take actions to reduce the risk of fall using a reduction program based on the policies and procedures in our organization. So, patients who are high risk for falls have an orange wristband, an orange tag attached to the bed head, and an orange triangle affixed to the patient's folder. We need to assess all patients inpatients for fall risk. This assessment must be done within 24 hours, and any reassessment needs to be done if there is a change in risk factors, post-surgery, new complaint of giddiness upon transfer from between wards, and post-fall. In the event of a fall, these are the things that we need to do. Assess the injury, carry out vital sign monitoring and mental status examination. Immediately inform the doctor to review the patient and initiate your post-fall management, which is to reassess the fall risk and to reinforce patient education based on the patient's fall risk. To assess the patient's fall risk, we use this scale called the Morse fall scale. This will be educated and taught to you during your nursing orientation. So here are the key measures to reduce fall. Once you identify as a high fall risk, ensure the patient is given the orange tag appropriately. The patient or the caretaker must receive fall educations and be provided a brochure or a video for their education purpose. Ensure the call bell is functional and within reach of the patient. Educate the patient on how to use the call bell by demonstrating on how to press it. Allow patient to show you how he or she presses it. Patients with significant risk of falls need to be transferred using the appropriate ambulatory aids and also the correct number of assistants. All patients who experience a fall in hospital must be assessed and examined by a medical officer on duty. Subsequently, the consultant in charge and the ward sister must be notified. All falls must be documented in the patient's progress notes, and an incident report must be raised within the same shift. So how can we reduce the risk of patient fall? First, we can set the bed at the lowest position, lowest height, and lock the brakes of the bed. Ensure both cot sides are up. Ensure the floor is not wet or slippery. Goes to the bathroom also. Check. Ensure that the floor is not wet or slippery. Advise patients not to wear socks. Screen patients' footwear or provide them with the hospital provided footwear. Lastly, we should practice cubicle nursing and do frequent nursing rounds to ensure patients remain in their bed and not attempting to get out of the bed themselves. So this is a summary of all our 6 international patient safety goals, which we can describe it as a head-to-toe approach, whereby we can identify patients correctly using our eyes, improve communication through our speech, improve safety of high alert medications with our knowledge, ensure safe surgery, safe site, again with our knowledge, reduce of healthcare risk associated infections with our hand hygiene, and reduce risk of patient harms resulting from fall, which we can look at our feet and know that patients shouldn't fall down. I thank you all for watching this video. Next, we can proceed with the quiz. All the best in the quiz.